Good afternoon, Dr. Dương Nguyễn Thị Mai Nga Dương. She will be talking about vernal conjunctivitis. This is very common, but the treatment is quite difficult for every doctor here. So today we are very eager for waiting your presentation today. Please.
Thank you so much. Good afternoon, everyone. And on behalf of corneal department, I'm going to concentrate on one of severe form of allergy ocular disease, that vernal keratoconjunctivitis conjunctivitis. As you can see on the screen, I want to give you a presentation about the systematic approach to managing of the patient of this disease in clinical practice. And I think my talk is relevant to doctors who are practicing every day at a clinical office, because most of these patients of the disease could be managed at our hospital. Allergic conjunctivitis comprise a spectrum of disease affecting the ocular surface, and this includes to mild form, that's seasonal conjunctivitis and perennial allergic conjunctivitis, and to severe form, that's vernal conjunctivitis and atopic keratoconjunctivitis. And VKC, vernal keratoconjunctivitis, is a recurrent form of ocular allergy. It's characterized by severe and severe and often bilateral chronic inflammation of the corneal surface, which can result in permanent injury of visual disability if not adequately recognized and treated. VKC most frequent in Asia, West Africa, and South America, where the weather is hot and warm. And mainly VKC is mainly in children and young adults, with onset often occurring in the first decade of life, about from 5 to 10 years old. And while it's considered a long-term disease, while a general subside before or just after puberty, but while it considered a long-term disease with an average duration of 4 to 8 years, VKC can leave permanent lesion in patients with severe disease. It's common among male than female, and despite a typical seasonal trend, perennial forms of VKC are more widely reported with acute exacerbation in the spring and summer period. About the pathophysiology of VKC, VKC is a T helper type 2 lymphocyte-driven disease characterized by infiltration of a number of inflammatory cell types, including eosinophil, mast cell, and T lymphocyte. This differs from atopic keratoconjunctivitis (AKC), which has been sorted from both T helper type 1 and T helper type 2. And this result in the release of a number of pro-inflammatory cytokine, including interleukin 4, interleukin 5, and interleukin 13, as well as other toxic cell mediator. The result in corneal damage and release of this factor mediate the remodeling ocular inflammation, and each that are commonly associated with VKC. And management strategy should be continued to be focused on taking specific of the clinical presentation and pathophysiology of VKC. Clinical signs of VKC include a papillary reaction of the upper tarsal conjunctiva and throughout the limbus. So the disease can be classified into 3 clinical subtypes based on the location of the papilla. That the tarsal form, the limbar form, and the mixed form. And severe VKC can result in sight-threatening complications, include superficial punctum keratopathy, shield ulcer, corneal scarring, keratoconus, liver stem cell deficiency, and secondary infection. And iatrogenic because of using long-term corticosteroid. Several critical rating systems of VKC have been proposed in order to standardize the management and improve clinical outcome. Currently, the best known rating scale is the Bonini scale, and this clinical rating system includes an evaluation of the severity of symptoms and conjunctival hyperemia and papillary erection and corneal involvement. And the author divides the VKC to 5 rate from quantum to mild, moderate, severe, very severe, and evaluation. And the severity of VKC is often used as an indicator for treatment when no improvement of symptom and sign within 2 to 4 weeks result in a step up in the management approach. More recently, Gokhan proposed a rating system based on severity of ocular sign and classified the severity of sign into 4 categories. And patients may have a finding that do not fall into the same severity, and the rating is done in both eyes independently. In this grading scale, authors stress the importance of the frequency of symptoms in the intermittent disease periodicity defined as inflammation free of 2 and 3 months, during which the patient is off medication. This will mean a maximum of 3 to 4 episodes in a year. When chronic disease periodicity is defined as inflammation-free interval of under 1 month, such a patient had chronic disease through the years. And intermittent may be safely given short course of mild steroid, but with chronic on year-long disease. This is a not good option to give a chronic continuous steroid therapy. But many ophthalmologists simply use personal, clinical note-taking to assess the progression of the condition and treatment effects, not using any rating scale. Controlling the sign and the symptom of VKC can be a challenge to even experienced ophthalmologists, and early detection and prompt treatment is crucial to minimize the sight-threatening complications. The overarching goals of treatment are not only control the acute symptoms, but also to prevent the recurrence and minimize treatment-associated adverse effects, so improve the patient's overall quality of life. Ideally, treatment should be individualized based on patient clinical status, and as acute exacerbation tend to occur during spring and summer, so initiating therapy at this time and continuing throughout the years. Treatment method of VKC include a non-pharmacologic measure, pharmacologic measure, and allergy-specific immunotherapy, and nowadays emerging therapies. First line management of VKC should avoid the identification of relevant allergen and avoidance of non-specific. Behavioral modifications such as wearing one-eye wrap or calf visual can help reduce contact with non-special environmental trigger and like dust or sunlight, and artificial tear can help boost and dilute potential allergen and inflammatory mediator and cell from tear film. Use cold compression during acute episode can provide temporary relief from sensitive complaints as well as from edema and hyperemia. And patients and caregivers should be given education regarding the chronicity and cause of VKC, how to install the eye drop and support in navigating the psychosocial stresses. Here's slide looking the therapeutic strategy. Given the chronicity and severity of the disease, non-pharmacological treatment option should be accompanied by pharmacology treatment. You can see the first therapy is allergen avoidance. Allergen avoidance, and everything we do after that is to prevent the that occur once that T cell. Everything once that T cell activity by the antigen, and at the end. At the end, we have to block the cascade and the muscle stabilize here to mast cell. Using a steroid to block the pathway of eosinophil and the B cell activation, and use of an immunomodulator, it blocks the T cell activation in this way. With the conventional topical treatment or symptomatic treatment, alongside antihistamine and we have a symptomatic treatment. We have a 4 group, include topical mast cell stabilizer, topical antihistamine, dual acting, and NSAID. So alongside antihistamine and dual acting agent, mast cells stabilize from the first line of treatment and are effective in reducing the signs and symptoms of mild and moderate VKC. And dual acting agents should be considered ahead of monotherapy with antihistamine or mast cell stabilizer. I choose 3 drugs in our hospital for each group. That's the Relestat, is an antihistamine drug. Allergisan of the group mast cell stabilized and partake with the dual active. NSAIDs are not recommended as they do not target the specific inflammatory mechanism associated with VKC. Topical calcineurin inhibitors are recommended in patients with acute typhoid or persistent, moderate, or severe VKC. That's not responding to anti-allergic drugs. Cyclosporin A is effective in control of ocular inflammation by inhibiting T lymphocyte proliferation and interleukin-2 production. It also induces histamine release from mast cell and basophils. And multi-study on the efficacy of topical cyclosporin for treating VKC have shown a beneficial effect of the drug and its steroid-sparing effect. And different concentration of cyclosporin from the 0.05 to 2% are currently available in different countries and has been frozen by diluting in castor oil or artificial tear. But there are no consensus on the minimum effective concentration of cyclosporin A to treat VKC. And now, cyclosporin A 0.1% continually is approved to treat in treatment VKC. The VKC, and it's recommended that cyclosporin A 0.1% should be initial twice daily for patients with mild to moderate disease and 4 times daily for those with moderate to severe disease up to 6 months. And cyclosporin A can be used in combination with corticosteroid in patients with corneal complications. And this drug, it has some side effects, that's transient stinging and burning sensation when installation. Tacrolimus is T lymphocyte and inhibits calcineurin activity. Tacrolimus may be administered as eye drop and ointment. However, the eye drop formulation is not approved in many countries. Now it's popular from the ointment 0.03%. And similar to cyclosporine, tacrolimus may be associated with installation pain. And as a strong immunosuppressant, topical tacrolimus with prolonged use associated with increased risk of corneal infection. And so it has to do with the monitoring of ophthalmologists. In the treatment of VKC, the steroid can be administered in three different ways: that topical steroid, toxin injection, and systemic therapy. Topical corticosteroid eye drops should be used as short and pulse therapy in a patient with persistent VKC in acute exacerbation or have corneal involvement, and have under the ophthalmologist monitoring because of increased risk of adverse event. And when chronic use, topical corticosteroid can be administered at low and high dose depending on the severity of VKC with or without cyclosporine. And some experts suggest a short steroid like hydrocortisone, fluorouracil, and loteprednol. And in the case of only conjunctival involvement, corticosteroid should be reserved for use after loss of control or persistence of symptoms with cyclosporine, and they not recommended for long term because of increased risk of increased IOP, glaucoma, cataract, and infection. In the severe form of VKC, the clinician could consider toxin injection of steroid and the steroid systemic therapy is rarely implemented as VKC treatment because it's a high frequency and severity of adverse effect reported. Allergen-specific immunotherapy only recommended when clearly defined systemic hypersensitivity to as an identified allergen acid, and is referred to an allergist or specialist ophthalmologist. Nowadays, the monoclonal antibodies, such as IgE blockade, interleukin antagonist, or antibody against salicylic acid binding immunoglobulin like lectin, is more popular and appear to be a protein treatment for refractory form of VKC. About the surgery, surgical approach should be performed only in severe giant conjunctival corpstone papular, serous corneal plaque, liver insufficiency, and other ocular subfibrillation that do not respond to medical treatment. And the surgery after VKC included cryotherapy and excision of giant papilla. In the case of corneal involvement, giant toxin papilla, and topsis, the debris of the corneal plaque have to remove cytotoxic cell and used in the case have a corneal ulcer of moderate to severe severity, and AFT can be applied in the deep ulcer in severe allergic patient and the slash trauma thinning. In the literature, it's a common idea that VKC should be treated step by step. Back to the Bonini scale rating, the author proposed a treatment algorithm with the base in the case of mild VKC. They use avoidance allergen, lubricant, antihistamine, and use drug of mast cell stabilize. And in the next step, the author impressed of the add-on the other medication depend on the rate of the patient, and each step and systemic treatment and surgical treatment only as on the very severity case. This figure summarizes the movie expert working group recommended stepwise management approach according to disease severity. When no improvement in symptoms and signs within 2 to 4 weeks, result in step up in the management approach, the new paradigm of the group, and the and symptom sign is not improvement. After 2 to 4 weeks of treatment, we should next in the step and group of actors in presence of dual activation is a head monotherapy with mast cell stabilizing antihistamine and topical cyclosporine is the first line after the base of dual acting, and corticosteroids should be only used in a short pulse and or after cyclosporine alone is not effect in conjunctival environment or in or corticosteroid. One can use combination with cyclosporine in patients with moderate to severe disease with corneal involvement. Allergens, that's intervention. This new paradigm is different with the conventional treatment. In the old treatment, they use a short pan of corticosteroid and systemic corticosteroid. In the first choice for the patient with mild or persistent to moderate severity of VKC, but now they prefer to use of immunomodulator such as cyclosporine and tacrolimus is the first choice in the patient from mild to severe VKC. With the Hoffman grading scale, patients should be treated with the first set similar to the Bonini and the movie group expert group, and they but in treatment algorithm, the moderate disease, the moderate to severe to blinding the patient, the blinding add-on therapy on the antibiotic based on the periodicity of disease. In the intermittent disease, the short-band and mild surface-acting steroid is required, but with chronic long-term continuous therapy with 0.5% cyclosporine and is severe in the severe case, the use of cyclosporine 1% or tacrolimus 0.03% ointment. This in the algorithm, they suggest a higher dose, a higher concentration of cyclosporine for the first story of the in the management of VKC. So I'm going to talk about a parent shift right. That's avoid surgical intervention, avoid prolonged recurrent use of topical steroid, and improve quality of life. In new paradigm, they consider age of onset and monthly recurrence as an indicator of disease severity, and they consider effect of daily life in child life as severe disease. And the use of calcineurin inhibitor becomes the natural choice with cyclosporine 0.1% and tacrolimus. And in conclusion, VKC is a chronic form of ocular allergy, imposing a burden on both patient and healthcare professionals managing and adequate and continuous treatment through good patient education and regular long-term follow-up are essential. And treating VKC should entail a stepwise approach. In a new paradigm of management, the use of immunomodulator, topical cyclosporine A, should be considered early, with topical corticosteroid reserved as an add-on. Short pulse therapy for persistent disease during acute exacerbation or in patients with corneal involvement, tapping once symptoms have been controlled to avoid adverse events. For patients with an identified allergy, referral to an allergist to recommend for additional systemic treatment. And in the rare patients who do not respond to medical treatment, surgery may be required. Thank you for your attention.
Thank you very much, Dr. Zhu, for your very good presentation. overall about burn or keratoconjunctivitis, and many is the approach for treatment is new day. So any question and comment for Dr. Zoom? Yes, Professor.